Once again, I'm going to do it without the mic, and I hope you can all hear me. We're going to take a look at the findings, and the group that I worked with, and the smaller breakout group that we have, took a look at Dr. Jensen's question, and how would we have this pertain to Western New York? What might pertain? Might? We were like, wait a second. Regardless of where we are in our Western New York communities, whether it's inner city, downtown, North Buffalo, the suburbs, the outlying areas, let's go to Springville. What might not pertain? We couldn't find anything that didn't pertain. That was the bottom line. And we looked at it and think, okay, what about the empathy piece? Everything's relevant to Western New York. All the findings. They don't discriminate. That's what we concluded. There is no discrimination when it comes down to these findings. Anxiety, depression, the high rates in Western New York, high correlation rates of trauma, the stresses. What about the early response? That's key to dealing with it. We felt that no matter what group of people we were talking about and getting responses from, the key was early response. It's just that we kept on saying, when? When do we begin that early response? And we figured out the sooner the better. Integrational cycle, just like this morning. We went right back to it. And one of the members of the breakout group wanted to know, what about the other side of the coin? What about the resiliency of the numbers that were not, succumbing to the stresses? What is it that they have in place in their lives that allow them to not succumb to the stress and the trauma, to become victims of that disease itself? And then we took a look, literally, we saw it, alcoholism, drug abuse, and then we looked at, wait a second, obesity, heart disease, all of it. It's a train wreck. The locomotive has wrecked. The other cars are right behind it. And that's when the true wreckage happens. What happens is it's a domino effect. What can we do to stop the domino effect, especially when we take a look at Western New York and the correlation to what's going on here with substance abuse? Access to services. We took a look at our infrastructure. And we said it was the infrastructure that might be creating a new set of stresses, because services are available. They're just hard to get to, especially if you are in the outlying areas. And we can't ignore the fact that we are the third poorest city in the nation. Our infrastructure and the rest of the dynamics to go along with it are impacting our ability as a community to respond holistically, to get together and deal with it. What we need to do is figure out how to come together as a whole and approach the problem holistically, instead of repeating treatment and duplicating services. What can we actually do to not duplicate but to treat holistically the problem within our Western New York community? And that pretty much sums it up.
Wow. I don't know if we were as clear, and I will say, and I don't know if other groups have the experience, we found Dr. Anda's data to be more difficult to put into a context of what do we do now. I think it was more of a challenge in some ways because of the more medically driven kinds of impact. So we were struggling with that. So more in terms of what do we do with this information. But we did talk about a couple of things. One, it brought, I think, to light significant need to somehow help the mental health professionals, which is mostly our group, interface with the medical professionals, and really sort of highlighted the gap between those two. So that was sort of an area that we wanted to focus on. Again, we talked about the schools. We talked about, again, with the medical community, assessing for trauma. We talked about what a hospital might do on the front end to be able to assess where somebody is at, and that even where we do that, it's done in sort of such a rote fashion and not a sensitive fashion that it doesn't seem to be a helpful intervention. Some of the things that the other group talked about, but we did also start to talk about where our programs and our efforts around accountability deal with and struggle with the lay community, really the entire community, in terms of behaviors that are manifest from trauma and how people perceive those around accountability. We talked about the legal community, how we need to involve the legal community as well. And we talked a lot about perception. People who would listen to this information who are not in service provider positions, sort of fearful that this information is used by kids and families as excuses. And sort of being able to wrap themselves around that. Hearing from families, well, they don't really remember trauma, so that doesn't fit. They don't remember these things. So those are the kinds of things that we struggle with. But I would say it was more of a challenge for whatever reason than some of the more individual reasons.
Our group came up with a couple of strategies, more broad, about what we can do. We talked a little bit right off the bat about some community maps, and in terms of law enforcement, if you look at where the most car theft happens, where the most arson happens, where the most burglary happens, it's all in little pockets in the neighborhoods. And then we talked a little bit about the medical side of it, that there's the incidence of asthma in more of those neighborhoods too. So it was kind of going along with the same data that these environmental issues have medical effects. And instead of trying to say, okay, in the city of Buffalo, I'm going to help all the kids that have asthma, instead going by community, or zip code by zip code, and trying to look at the problem holistically. And we also talked about treating family as clients instead of just saying that, okay, we're going to fix Bobby because he experienced these traumas, but treat the family as clients, really take a holistic and comprehensive approach. And another thing that came up that was similar to what we had talked about before too was having this common language between groups. And someone who said they worked in 4 different similar agencies, and all the agencies treated the same problems with different language and different methods of trying how to fix it or whatnot. So just developing more of that comprehensive. And then finally, mobilization is something that came up. There's a lot of us that, okay, now we have this information, and there's so many people that do care, that do come from a place of wanting to make systemic improvement. So actually getting to that point, and whatever that way is, but getting to that mobilization.
The group that was in this room actually found that the data really wasn't surprising. And for practitioners, they see the link, but now we have actual ways in which it has been studied, and we have a backup and support system that's based upon fact-finding that we received from the information we received today. The time to break this cycle is now, and this group felt that there was real urgency in terms of doing preventive and intervention services out in the community. That in terms of the community, we have to educate and expand the base of knowledge so that this community shares more common goals and therefore comes up with solutions that we can get buy-in from all of the sectors that are involved in addressing individuals who have suffered from trauma. We felt that one of the significant issues in this community is that there are so many needs and there are conflicting priorities. So obviously it would be very helpful if we could get everybody on that same page. We need to begin the process of addressing it at the very beginning. I think the individual comment that was made was it needs to be started when people are born. Because when you look at the data and information, it really needs to start at the very beginning, because in that first 11-month period is where we saw the most significant issues of trauma for newborns. We are a community, a singular community, and this is not an issue that is limited to our community, but of course the impoverishment in this community creates a whole different level of stress on individuals that we, as a community of Western New York, really need to be concerned about. And it's just not the city of Buffalo being the third poorest city, it's the city of Buffalo really being the hub of the region, and it impacts the entire community, what happens in Buffalo and to people in Buffalo. And that there is a body and mind connection, and we have to have a broad approach to solving this issue, and the data gives us a starting point for really being very strong advocates with data to support our case, which we probably therefore haven't really had much of. So that was out.
Thank you. I pushed a couple of hot buttons. A few things. The not surprising part is really interesting because, really, it's very interesting because the first time I presented this to an audience, it was social workers, and I sat at the table and they said, we all knew this for years, but nobody had the data. And what they told me is, thank you, because now I can go back and use the numbers to justify our position on this. The other thing that this work was incredibly hard to publish at the beginning. Nobody wanted it. Major medical journals said, we don't believe it. You can't believe what people tell you, they're making it up. People who make things up also make up other things. They make up their childhood experiences. They make up their symptoms. That's what we got. That was 1998. So the not surprising part, I think, is not surprising for you. It was very surprising to me. I was a cardiovascular disease epidemiologist. I had no idea what we were going to find. So I want you to be, it's important to understand that it's not surprising to some people, but some people, many people, probably most people, know nothing about this. And you work in a field where you're immersed in this every day. And I think that gets into the idea of public health. You know it, but the majority of people like that don't know it. And the thing that bridges the gaps between all communities is this is everywhere, and every community should know this. At the lay level, in the educational systems, and every service system where it's not already known. Frequently there is, I've been in public health for 25 years, and I'm always surprised how little most communities know about basic principles of public health. In order to, I found at CEC that in order to address a problem, you have to define it and describe it inside out, backwards and forwards. And in terms of whether this is a problem in this community or in the other community, having local information is shown to be really powerful in public health for getting policy change and getting people who push the budget buttons change, educating legislators. And I want to tell you that you do have the opportunity to get this type of information on a population scale for the state, or if you can get the funding for this particular region from a random sample of residents. And that's through your state health department. If you want that, you can ask for it, ask them to collect it. It's a choice, it costs. The state of Washington just got a grant to do that from the Gates Foundation to add their surveys. There's 4 other states that have just finished completing it so that you can educate the people that don't know, which I can't prove it. I believe it's probably the majority of people in the state of New York that really don't understand this stuff. Resilience. That's tough. Resilience. One of the reasons that I showed the hydro is probably the best example, is that in the field of the study of resilience, which is a relatively new field from a research perspective, the terminology I find confusing, and it's in its embryonic stages. And if you say somebody had a lot of trauma, the childhood, and they're resilient, I say, well, what did you measure? They're not an alcoholic or a drug addict or a major depression. But, if you dig deeper, you may find that they have 3 or 4 other human functional issues in their lives. So I think take care with the term resilience. I don't believe there's any bulletproof case. You can do anything you want to a child or some kid that's going to work out okay. I think that's a fallacy, and I think we're overcoming that in the field. We designed this in 1991, so please forgive us if we're not up to date on what we collected. But in 1991, we were thinking about adversity and not positive things. And I've learned by doing this and going to many meetings that I sort of view, and I don't like the word resilience, I view as positive a balance of positive and negative input in children's lives. So it's sort of like I see the blind justice scale, and we got to take the blinders off the kids. We shouldn't be blind. To any of this, we shouldn't be blind to the adversity and stress, and we want to tip the scales. I describe the adversity. We also know what are the good things to do for kids. How do we enhance early childhood? And I really think that the key is early childhood development. So part of the challenge is to reduce the amount of toxic stress at a population scale, and also on a population scale, put in the positive things that maybe lead to better functioning in the presence of adversity. Not whether or not you're resilient. I see it as a balance in people's lives, and I see it as a balance on a population scale. Something was mentioned of early childhood. I'm trained in internal medicine, tertiary care, and I'm still recovering from that. And it's just in the last few years that I have come to believe that this is about, ultimately it's about, the big payoff is in early childhood. And in prevention, it took me 10 years to understand that the distinction between primary and secondary prevention in this field is really sort of stupid. Because if you don't have a baby coming into a world where there's somebody who's capable of interacting with them in a way that's healthy for them, we don't have that. So in order to do that, you have to involve the people that have infected with trauma already, and to nudge them towards higher levels of functionality. One of the barriers to change here that I frequently see is, well, tell me what to do. I can't tell you what to do. But I see this as incremental change over time. The bad news is more stress is worse. The good news, I believe, that correlates with giving hope is if you dial it down, and things will probably get better. There will be fewer people abusing drugs and alcohol, fewer people getting infected with the HIV virus, and all these other things that I mentioned. I'm not sure the distinction. I've sort of, in my own mind, I've lost the distinction between medical and behavioral. I do that. So I'm not sure what you're struggling with there. To me, they have become sort of, in many cases, in terms of prevention, one and the same.
I think it was that concept of same language.
Yeah.
And speaking on the same page, and seeing the totality. So I think it was more like that same language issue.
So somebody in one of the groups mentioned other countries' international work. We're working with the World Health Organization now. We've had one meeting. We had people from many countries around the world look at this information, and honestly asked them whether they thought that it would apply in their countries, and they generally agree yes. And they have added. We have a questionnaire now where other countries that add things like slavery, human trafficking, growing up in a war zone, those kinds of things that may apply in different countries. And so this is going to be, in the next few years, described as a United States problem, state by state, and a global problem, so that the communications, I think, will spring out, and you'll see that there are more and more people engaged, so that you can use the language that we're developing here on a broader scale. Poverty. I'm not going to pretend that I know much about poverty. I didn't grow up in poverty. I lived in it. I do believe that the kind of things we talked about today are a pathway to poverty. That they do lead to poverty, and there's an expert on, they probably sustain it and make it hard to get out. And that leads me to, in public health, that there's two approaches to most common problems like this. One is the one that most of you use is the high risk approach. The high risk approach is people that come to you or people that live in poverty are at high risk, or going out and doing nurse visitation programs are usually targeted towards high risk families, and that's where the big payoff is. If you can change things in a high risk group, then you have a bigger payoff because you get a greater risk reduction for your buck, and that was done in cardiovascular disease, and it still is today. So there's public health analogies, but the thing that I think turbocharges your high-risk approach is having critical mass of public health awareness about the problem that you're addressing, so that you can have your clients come in and already know this. They already know it, so you don't have to be continually teaching it over and over, or your colleagues know it, so that when you refer somebody to one of the other services that are so complicated, that they will understand it too. If there's anything else you'd like to address, I can do that. Those are the notes that I took. Or I'll take general questions. Sandra.
Any replication of this in an urban population, people of color, poverty, high levels of community violence, because those weren't even the community violence questions weren't even element. So is anybody going to do that or trying to do that? Or
I don't know. I see in the literature more and more studies using the types of measures that we use. Like I see them from the Philippines and Japan, and in various populations, in prisons in Japan, in schools in Japan. The data system that I mentioned, the state-level population data, is going to be able to examine what we're talking about, because it's not done in a wealthy, primarily Caucasian population. It's a random sample of the state, if you will, here, or wherever it's done, and in that database will be race and ethnicity, measures of socioeconomic status, whether or not you have insurance. It can be done, if the sampling is done properly, you could even get down to census tracts if you have the resources to do the sampling. So to me, it's now just having the will. The methodology is there. It's having the will and asking for it and finding the resources, which are not great to describe it for the populations you want. And I'm convinced the thing about poverty is that this is just human biology. I mean, we're going to find the same things in Saudi Arabia and countries in Africa, that you stress Homo sapien children, and you get, our brains are not different. So this, I'm convinced this is going to be similar findings no matter where you go. The level of stress is going to vary from group to group. Yes?
Is there a way to recovery show the picture of two brains and one is more developed than the other? Is that something a child who has another damage to brain that he can recover from, and there's a point where he cannot recover from it?
Would somebody please ask me an easy question? Recovery. I mean, I'm not a nihilist about this. One thing I can't tell is there's several things, and I'm going to backtrack a little bit. I forgot to point in your question brought up. There's a difference between what we do, which is epidemiology for populations of risk. Adversity is not investigated. At the individual level, so if you do individual treatments, you might say, well, why did this? You try to explain for one person why things are happening the way they are. This is public health epidemiology, so we can create policy in public health population focus. In terms of things getting better, my guess is that remaining orphan is in trouble. That doesn't mean it can't get better. I don't know who has treated people with brain scans that look like that. Has anybody here done that? When they look that bad? I don't know. There is hope. The neurosciences are telling us that the brain is probably much more malleable and plastic than I learned when I went to medical school. I learned that it turned us nuts. When you get an adult, it was like a rock, and it couldn't change. And now people, I think, are finding stem cells and ways to promote neurogenesis and neural growth, and that's the future. So there's hope, but for something like that, right now it's hope for the future. Yes.
You said that in the beginning in the 1990s, that medical journals didn't want to take the study seriously because of the methodology that was involved in terms of people self-reporting. But then at a certain point that changed, obviously, because the study has been published causes to confirm, whether or not the conditions they reported were actually substantiated by the medical records?
Okay, the first question is what changed. I don't know. I think success once we did the first one, and there was great interest in it. I think that journals compete, and I think part of it is that other journals started to want the information. I think some of the first part of it was that it's the luck of the draw with people that review the data. If they're threatened by it, they don't like it. I think there were a lot of threatened people who didn't want to deal with this. Part of it was I won't name the journal, but several major medical journals said, well, this belongs in family practice, or this belongs in addiction medicine. It didn't go. Nobody wants to own it. And I think there's a secular change now that there's more ownership of these issues everywhere, and that's probably what changed. The fact that you all know this, that more and more reviewers sort of knew it and were willing to consider it as an issue. What was the second question?
The second question was in terms of the symptoms, the medical symptoms, the heart disease, etc. Were those confirmed the people who answered the questions were part of the study, and then were tracked with tabbing?
Where we have so far, we've been able to do that, and we'll do more in the future. For example, like folks, they have lung disease. In the follow-up period, we looked at hospital discharge diagnoses for lung disease, and instead of discharge diagnoses, we looked at medications used to treat only chronic lung disease, and the prescription rates for those people up. So the self-reports and the hospital discharge and the pharmacy data all sort of support each other. And we've seen that for several conditions, but it'll take time to do that for others. Yes?
This may be more of a comment than a question, but it just appears to me when you talk about toxic stress and how, I guess, surprising that is for people. I can't help but to think that a part of what makes this such a problem is the attitude that children don't have stress or don't like their only child, so much thinking and stuff, things like that. And that is the problem of something else obstacle in the way because that attitude and the public health and the other things sometimes trying to create.
My hearing aids didn't pick you up. I'm going to have to have somebody repeat that for me. Somebody who hears better than I can repeat that for me. No?
I got it. She was commenting that part of the problem here is people's attitude that children don't experience stress and denial that children experience stress, and perpetuating the non-intervention on behalf of children.
And that's an issue, that's an area. Raising that as a area. Yeah. I'm going to think about those people 10 years ago. I think information helps to break down the barriers. Documenting it like something or Sandy?
I really think we're in the process of recognizing, but still in the process, that children are human beings. Now, this is the only country in the world that has not signed on to the UN rights of the child. The only, other than Somalia, which doesn't have government, the only country in the world that has refused to sign that as part of the UN. So, and I think there's a long history. When you know the history of childhood, children have not been considered fully human until they're 18 or 21. And I think that's a big piece of what you just observed.
And the other thing is understanding from a proper conceptual perspective as adults what child is as a being. Because I know I was at a presentation a few weeks ago where a prominent researcher was talking about meta theory. Your theories about that you use when you hear your kids, that your preconceived notions about what a child is. Mine were like half the time it's totally wrong. And that's why I said, I think during that presentation, that children, their job is to protect children, and that they will seek what they need out of the environment, and we need to have them in an enriched and safe environment, and not try to program them which is sometimes where I've done with my kids. So some of it is as the research comes out about what little children are really all about and what their developmental needs are, is I think some of that will be over time. In fact, not more than 20 years ago, there was a belief that infants couldn't feel pain, and surgery was done without anesthesia. Not too long ago.
Right. I have a comment sort of to piggyback on that, and kind of a plug for caring for the caretakers. I think it's not very easy for parents to admit, teachers to admit, doctors to admit that their needs or their desire for how their day goes is competing with their child's demonstration of their stress. I think it perpetuates adult denial that kids are just being bad and they should shape up and quit showing, this bad behavior, which often is their way of showing their stress. And I think there's competing needs in children's systems. I think, I in the child welfare system for years and years, and that was a constant issue with foster parents, when kids would come in with all their reactions to their placement, and they weren't being good. And I think if we don't help parents with what their needs are, they just are much less likely to be open to understanding the emotional needs of children.
I heard last night at dinner about something about that was really exciting, the idea of doing, and I don't know the terminology, I'm sorry, basically trauma-informed, family-based treatment. Is that correct? That sounds really good to me. My intuition says, hey, that's going to really show those benefits for everyone. If the child, treating the child or the parents, not and, or rather than and. The educational system, you might want to know that there's places around the country that are trying to basically create trauma-informed schools, public schools. I think that's one of the most exciting things that I've heard in a long time. In the state of Massachusetts, there is a movement called Helping Traumatized Children Learn, where they have a school system that's funded by the state, and the idea is to go into the school and train everybody in the school. It's sort of like the sanctuary model for schools in ways that to train the administrators and the teachers that to behaviors like you talked about, that that is a behavior that may be related to this child's experience. It's a natural form of expression of their experience, and to relate to the child differently, and not, at the very least, I see that as making schools less traumatizing for traumatized children. I don't know if the schools can actually treat, but at the very least, if we dial down what I talk about, dial down the adversity they face in the school systems, or in the juvenile justice systems in the state of Washington. There's a brave woman there who has found her way into the system, and the data that I showed today was very hard to get, and we've had dialogues with the judges and the parole officers, and then connecting with the schools, and now they're starting to talk to each other. And last night, as another example, at dinner last night, I'm thinking of all these things, for veterans, having a different judge. The veterans that come back from situations and have behaviors related to their trauma experience in battle or in the war, and say, hey, wait, that should be the same thing. That should be that way throughout the justice system, especially probably juvenile justice, because they're really high risk for going on into the tumbling into the adult system. A friend of mine at CDC, we were sitting having a beer somewhere last year, and said, if we were like the evil emperor of the universe, and we must say, okay, if we've got traumatized kids in the justice system, if you were to be really evil, what would you do? Incarcerate them. And it's a not so fun job. You want to make it worse, you take them away from relationships, you put them in a relationally impoverished environment, When the fact is what they need is enriched relationships with people who have the capacity to interact with them that have been in an enriched environment. And how many people like that are there that are incarcerated? It's not what they're there for reasons, but they don't have, the people in that environment don't have the things to give away to them because they never got them. And so, and the same thing happens in some of the institutionalized spiritual. They go into relationally impoverished environments. I could prattle on for a while. I was going to try it out. Any other questions?
I got a question. I do understand the fact that when we talk about the general biology and human growth and development, I think over the years I've heard the same thing about mostly destructive behavior. We talk about human biology and how the body and the brain work, human growth and development. But now we're using that instead of destructive behavior. I hear more about trauma. I'm losing my thought. I'm really more concerned or interested in, now that you've brought through your research and literature what is actually at the forefront of people's minds about the traumatization that's going on, not just in the minority community or the poor community, but throughout the country, throughout the world. There's trauma from war and from earthquakes and stuff all around. And we know that there's a need for intervention. And oftentimes intervention starts in the schools and the community agencies, but it stops after a while. I'm wondering what is going to provide the accountability and oversight to keep training and information like you presented to go forward so that we will stay on track with dealing with the trauma, being able to identify it and address it. And I'm wondering, what is your next plan after you present this information?
I think that what you're talking, the hard part here, but I think the pot of gold is getting this to the legislature and getting policies written where this is what you have to do. The K-12 systems, public health system, that's law, right? That you have to learn certain things and you got to pass certain things, and the curriculum. Well, why can't issues like this get into the public health policy, or educational policies, so that it doesn't go away? Do you understand that it becomes sort of the rule of the culture that this is what we do, and then it won't go away. It doesn't require climbing the mountain, with conferences and these huge efforts over and over and over again. Somebody mentioned you mentioned that you knew this 10 or 20 years ago, and then a new cohort of people comes in who don't know it, and you got to start all over again. So it's really policy. That's my solution. Is that policy has to be shaped by you and by the information.
You got a lot of work.
I haven't quit yet.